All right, this is going to be covering psychiatry exam number 2, and this is a medical school lecture. This one's mostly covering mood disorders, thought disorders, anxiety disorders, and then a lot of the pharmacology of how to understand these. So let's just go ahead and get started here. So first of all, mood disorders. We understand the word euthymia, which is up here, means normal, okay? So there are moods that are below euthymia, or below feeling normal, and moods that are above euthymia, or above feeling normal. So moods below euthymia are things like adjustment disorder. This is where you have a unpleasant thing happen to you, and it just kind of messes you up for a while, and you're kind of in a bad mood, or a sad mood, or a down mood for a while. Then there's dysthymic disorder, where you are essentially down for a very, very long time, almost every day. You don't get better, for more than 2 months. You're just always down pretty much every day for a long time. Then there's major depressive disorder, and this one's characterized by the depressive episode, which lasts about 2 weeks usually. And there are 2 types of depression. There's atypical depression and there's typical depression. Atypical depression is pretty much exactly like typical depression, except for the person, instead of being not able to sleep and being tired all day, these people sleep all of the time, and they're very, very low energy, and they're also very, very hungry. So they usually gain weight with atypical depression. Whereas with typical depression, came up with this thing, LSD or LDS camels, whatever, and so this represents basically how you can find out if somebody has depression. So first of all, life interest, L for life interest. So they don't have any interest in most life activities. D, depressed mood. So obviously that's makes sense. S, suicidal thoughts, or something they call suicidal ideations. C stands for concentration, and it's just bad. Appetite is gone. They don't have much of an appetite. See how this big time differs from atypical depression, where they have a large appetite. Next one here, memory. Their memory is poor. Their energy is low, and that is similar to atypical depression, except for in atypical depression it's very low. They also have decreased libido, and their sleep is disturbed. So the sleep one's also similar to atypical, except for the difference is that these people may not sleep very much, whereas these people sleep all the time, like 14 hours a day. So some typical drugs, if someone were to come in and they had major depressive disorder, you might start them on sertraline, which is an SSRI. I'll explain all this later. I'm just getting you a little bit exposed to these things. And then you might put them on, if that didn't work, you might try bupropion. And if that didn't work, you might try amitriptyline. And if that didn't work, you might try a monoamine oxidase inhibitor. Don't worry, I'll explain all those later. This is a long lecture. Next one are moods above euthymia. So this is above normal. So one example here would be bipolar, but really hypomania is like a bipolar is characterized by the manic episode, where basically this person they can't sleep hardly any hours. They have their goals get crazy, like I'm gonna go build a pyramid. They basically they take big risks, they spend all their money, these kinds of things like that. That's mania. Okay, hypomania is kind of the same as mania, except for less of it. Okay, it's not quite as extreme. They might just be like having a lot of energy and that sort of thing. I'm not getting very technical here because it's we can cover that kind of stuff later in another lecture. Anyway, there's 2 different types of bipolar disorder. One is type 1, and that is where it's just characterized by mania. Now they might get depressed in there as well. That's possible, but it's characterized mostly by this manic episode that occurs. Type 2 is first they feel low and depressed most of the time, and then they might have kind of a hypomanic or manic episode. And then there's the mixed type, which has got lots of lows and lots of highs. Some medications you can give for people who have mania is you can give them lithium or lamotrigine. And if there's psychotic components to it, like delusions and hallucinations, you might add antipsychotic drugs, typically the atypical antipsychotics. We'll go into that later. Don't worry about that now. Okay, so now anxiety disorders. Let's talk about these for a minute. So if you remember up here, I talked about there was mood disorders, thought disorders, and anxiety disorders. So first we talked about the mood disorders. Now we're talking about the anxiety disorders. So anxiety disorders are basically, you know what it's like to be anxious about something. But there's 3 different kinds of anxiety disorders in general. There's ones with a psychosocial stressor. In other words, let's say they went to war and there was bombs all over them, people dying. Or maybe they just failed a test, and now they're really anxious about tests, or whatever. So that's the acute stress disorder, and that lasts about 2 to 30 days. Whereas the post-traumatic stress disorder, this is where they keep on, both of these really, they keep reliving the event. It's just really messing up their life, making them anxious and on edge and irritable, and they're living in fear constantly. And this is where post-traumatic stress disorder is where it lasts greater than 30 days. Then there's pervasive anxiety. And this is where they're not necessarily, there wasn't any particular psychosocial stressor. It wasn't like bombs falling or failing a test or, getting a divorce or something like that. But it's something like they just always are feeling this pervasive anxiety. And in generalized anxiety disorder, it lasts quite a while. And they just are, they're not really anxious about any particular thing. It's just, they feel irritable and anxious and they're just like that all the time, pretty much. Almost never get over it. Disturbing their sleep and that sort of thing. Tighten muscles. Obsessive compulsive disorder is where, now this is not the same thing as obsessive compulsive personality disorder. Mind you, those are very different things. But obsessive compulsive disorder is where there's something that they're very anxious about and they have this compulsion. They can't help it. They know that it's not reasonable, but they just can't help it because it makes their anxiety go away. They have to go do this certain action to try to help their anxiety. For example, they were just, let's say they went to the bathroom and then they maybe thought they got a little bit of poop on their hands and they washed their hands once and they know that once is normal and that's what they should do, but the idea of it, that having some poop in their hands gives them so much anxiety that they have to wash their hands again. And then that made them feel a little bit better to wash their hands, so they wash their hands again and again and again and again and again. And it just, it just alleviates their anxiety to do this compulsive action, so they can't help it. Next is social phobia. This is where they have particularly a fear of social embarrassment. So let's say they went to class the first day and something embarrassing happened. Now they're just avoiding it all the time. Agoraphobia, this is, a lot of times people think of it as fear of crowds. It's kind of that, but mostly it's kind of fear of leaving a safe area. They're afraid they're going to have a panic attack. Sometimes it's described as fear of fear itself. And then there's also discrete anxiety. This is panic disorder or specific phobias. Panic disorder, don't confuse this with agoraphobia. Agoraphobia is a fear of having a panic attack all the time. This is where panic disorder is where they actually have a panic attack. Now, a panic attack only lasts like 5 minutes. Okay, they feel like they're going to die. Their heart is beating out of their chest. They almost pass out. They're sweating profusely. The ceiling is closing in on them. They have to run for their lives. Not necessarily, but that's how it feels. And the disorders, they're having these regularly. And then there's specific phobias where they're afraid of some particular thing horribly. Okay, how do you handle these people? One way is sometimes we use something called benzodiazepines or benzos. An example would be something like lorazepam. There's other things too, but that's a good start. Okay, next one here, thought disorders. Okay, so this is things like schizophrenia or other psychotic comorbidities or delusional disorder. Okay, so starting here with delusional disorder. A delusion is where somebody has this belief that's not true, and it's obvious that it's not true, but it's not obvious to them. And something sort of like they think that aliens are trying to communicate with them all the time, or they think that their neighbor is spying on them all the time. Just something ridiculous. It's been if people the police come over and they say, no, your neighbors aren't spying on you, and they're like, well, the police must be in on it too. It's that kind of thing. Just a really bad persuasive. Every other area of their life is normal, but the delusional disorder is present. And then schizophrenia, Now, there's 3 kind of levels of this, and it really just has to do with the time. There's a brief psychotic disorder. That's less than 1 month. This is where they have hallucinations, they hear voices, that sort of thing, or they have delusions as well, and disorganized speech. There's negative symptoms and there's positive symptoms of this. Positive symptoms are things like the hallucinations and that sort of thing. And negative symptoms is where they have a flat affect, or in other words, they kind of don't have any emotion or expression, and they stop grooming themselves and that sort of thing. And then there's, but that only lasts less than a month. Then there's schizophreniform, okay? This is basically where you have those same symptoms, but it's lasting for 1 to 6 months, okay? And then there's schizophrenia, and that's where it's greater than 6 months. This is the full-blown thing, okay? Now we've got the psychotic comorbidities. So for this one, we have major depressive disorder with psychotic features. So this is where they were depressed first, then later they have some schizophrenia symptoms. Probably they got so depressed they started losing their minds, okay? Then there's schizoaffective disorder, and these are people that were schizophrenic first, and then later they might get depressed about it or something like that. And then there's manic psychosis, and this is where a person has like bipolar disease, and the mania becomes so intense that they become psychotic. For example, maybe something like someone believing that, I'm trying to think here, that they are Pharaoh of Egypt, or no, that's not a good example. I don't know. They get the mania, and the mania leads to some them hearing voices and having delusions and all that kinds of like that. So some examples of medications they might give for this. You can give the atypical antipsychotics like quetiapine, or if they're having an acute episode, you might give them haloperidol and some benzodiazepines to calm them down if they're like violent or might hurt themselves or something like that. Now there are different types of schizophrenia. The catatonic, this is where they like don't talk, they just sit there, they're all quiet. I don't remember what that one. I think that's one that lasts a long time. I'm not really sure. Disorganized, this is where their speech doesn't make any sense. Like the window is jumping at me. Lima beans are flavored like grape juice dripping off a, I don't know, just sounds like crazy speech. And then there's paranoid, where they think everybody's trying to kill them and, chase them down or whatever. Everybody's against them. And then there's undifferentiated, which is kind of one that doesn't fit these other categories. So, next here, treatment. And the treatment is going to be covered later on, but I'm trying to get lots of exposure to this, okay? So remember, you've got mood disorders, anxiety disorders, and thought disorders. And each one of these is going to require a different kind of treatment. And there's different situations for each one. For example, what if a person has a mood disorder like depression, but they're also feeling anxious? Well, here are some medications you can give for that. Escitalopram, venlafaxine, paroxetine. And the point of me going through this, I'm going to read a lot of these to kind of get you familiar with some of the sounds of these words. So that these words and these ideas are in your brain, and we'll cover them in more detail later. What if somebody has a mood disorder like depression, and it's the atypical type? What do you give for the atypical type of depression? Well, bupropion or fluoxetine. Okay. What if they, a lot of times when people have these mood disorders and they take a medication, it will decrease their libido. What if somebody really doesn't want that to happen? Well, you can switch them over to bupropion, and that'll fix that. What if a person has depression, they're really worried about having withdrawal symptoms or something? Well, you can give them escitalopram or put them on fluvoxamine. That's to decrease withdrawal symptoms. What if somebody's on a mood disorder, or they have depression, and they really want to lose weight as well, or they're maybe overweight? Well, you can give them bupropion. That helps with that. What if somebody has a mood disorder like depression, and they're really skinny and they need to gain some weight? Well, you can put them on mirtazapine. What if somebody is depressed and they're also having those bipolar symptoms we were talking about earlier? Well, make sure you always give them lithium first, okay? We're going to talk about all these drugs later in great detail, but this is your first exposure. So give them lithium first. That's kind of that's going to kind of stabilize the bipolar disorder. Then give them an SSRI. Now the reason for this is if you give them an SSRI, and let's say they have type 2 bipolar disorder, it's going to throw them into a manic episode. And those manic episodes are dangerous. In fact, it's under the manic episodes where people are most likely to commit suicide. So you need to be careful and get the lithium first. Another treatment for this could be lamotrigine, which is an anti-seizure medication. Okay, so what if they have menstrual depressive disorder? Okay, I just put menstrual cholesterol stuff here. Well, you can give them fluoxetine, as well as the mood, depression. Give them fluoxetine or sertraline. What if a person is depressed and they have bulimia? Well, you can give them fluoxetine. That's a good medication for that. What if a person is depressed and they're taking some other drug that is involved with CYP2D6 metabolism? Okay, I don't want to go in through the detail. Basically, it's a liver enzyme metabolism system, and certain drugs will affect it. And if you take other drugs that also affect it, it can really mess up the levels of those drugs in the person, and it can have dangerous side effects. So if a person's taking a drug that's being metabolized by these, drugs that you can take if they're for their depression are sertraline is usually the one we think of, but also escitalopram, venlafaxine, or mirtazapine. What if they have a depression and they want to quit smoking? You can give them bupropion. If they're just depressed, this is kind of the order here. I mentioned this earlier. First, you can try sertraline. This is an SSRI. Then you can try bupropion. If that doesn't work, you can try amitriptyline. And if that doesn't work, you can try a monoamine oxidase inhibitor. Now, amitriptyline is a tricyclic antidepressant. Bupropion is a norepinephrine serotonin blocker, and sertraline is just a serotonin reuptake inhibitor. Okay. All right, that's all the mood disorders. Now you've got exposure to some ideas here of things you can give. You can refer back to this. I'm going to cover it several more times. Here are all these conditions and all those drugs. You've heard the names. Now we're moving over to anxiety medication. So if somebody's got anxiety, usually you give them benzodiazepines. Particularly for anxiety, you're gonna think of alprazolam, lorazepam, and oxazepam. And I'll cover these in more detail later. Alprazolam also can deal with general anxiety disorder, panic disorder, and agoraphobia. Okay, alprazolam might be a good one to remember for that. Next here are thought disorders. This is our a schizophrenia type. Okay, so if somebody's got a thought disorder and they want to lose some weight, okay, aripiprazole rather. What if they have schizophrenia or thought disorder and they want to gain weight? Well, olanzapine is a good one for that. What if they've got a thought disorder? And one of the things about some of the typical and atypical antipsychotic drugs is they can cause these symptoms called Parkinsonism-like symptoms. So basically, it looks like they have Parkinson's disease. Maybe it's the lip smacking or the jittery type movements. If a person has this kind of disorder, what you can give them is you can give them a drug like hold on one second. If a person has sorry about that, thought disorder. Let's see. They do not want these Parkinsonism-like symptoms. You can give them quetiapine, and we'll talk a little bit more about the Parkinsonism symptoms. Well, maybe I should. Well, yeah, I'll talk about more later. Also, if they're having an acute episode of like schizophrenia or something like that, you can give them haloperidol or lorazepam to kind of calm them down. If they have bipolar disorder, you can give them lithium or anti-seizure drugs. And if they don't want the sedation, like maybe they're sleepy all the time, you can give them something like clonazepam. Okay? All right, now lots of exposure to lots of drugs. Probably right now you're thinking, oh my gosh, this is super unhelpful. Why did I even watch this video? Well, now, later on rather, we're going to cover all these and explain them all, so don't give up on me here. All right, so this is an overview of all the antidepressants, okay? SSRIs, tricyclic antidepressants, monoamine oxidase inhibitors, SNRIs, and norepinephrine dopamine reuptake inhibitors, and 5-HT2A antagonists. So there's a lot of different drugs here, and these little pictures, you're probably wondering what those are for. We're going to get to that, okay? Just looking here, you can kind of explore this. The antidepressant, you want to go to the SSRIs, it lists them all out here. Fluoxetine, vortioxetine, paroxetine, fluvoxamine, sertraline, escitalopram. You can see here lots of 2D6 inhibitors there. Oh, here's the 3A4 inhibitor. This one, less weight gain. Oh, we mentioned that earlier. More weight gain with paroxetine. Fluvoxamine can be an OCD treatment. Sertraline has the low drug interactions. We talked about some of these things before. Now, as a class, here are some of the uses. MDD stands for major depressive disorder. GAD stands for general anxiety disorder. PMDD stands for premenstrual depressive disorder. And OCD stands for obsessive compulsive disorder. Some of the adverse effects of this class are nausea, vomiting, diarrhea, low libido, headache, insomnia. They're all category C pregnancy, I believe, except for one, which is paroxetine, which is category D. Also risk of serotonin syndrome. So recognize here that because these are selective serotonin reuptake inhibitors, they leave lots of serotonin in the synaptic cleft. And so if you take something else that also increases serotonin, this person gets something called serotonin syndrome, which is very dangerous. Their hypertension goes super high and they can die. All right. So those are the SSRIs. And I'll explain this this ox here, the flying ox, a little later. Another antidepressants, typically second line though, we'd go over here to bupropion, norepinephrine, dopamine, NEDA, reuptake inhibitor, okay, as a unicyclic. This is a nice one because it has no libido effects. A lot of these other drugs, the big thing about them is they lower your libido, whereas bupropion does not do that. It's a CNS activating drug, so sometimes you can get some agitation, insomnia, and anorexia, those sorts of things when you are activating the CNS. So other antidepressants, a lot of times they kind of group SSRIs and SNRIs together. It kind of just depends on the kind of depression, and with a lot of these drugs, you try one, if it doesn't work, you try another one. I'll talk through these SNRIs real quick here though. Venlafaxine, desvenlafaxine, duloxetine, milnacipran, levomilnacipran. So venlafaxine, we're looking at tachycardia, hypertension, that sort of thing. Desvenlafaxine, this is renally excreted, so it's a once daily drug, has a half-life of 11 hours or something. Duloxetine is going to have the CYP2D6 and 1A2 metabolism, some hepatotoxicity with it. Sweating and a dry mouth, because I believe it does a lot with the muscarinic, or maybe it's anticholinergic, can't remember. Milnacipran, this one is only approved for fibromyalgia, and then we've got the levomilnacipran, which has the 3A4 metabolism and is only for major depressive disorder. Some of the uses here are, major depressive disorder, general anxiety disorder, premenstrual depressive disorder, pain neuropathies, and fibromyalgias, as well as stress urinary incontinence. I know we didn't talk about that over here, but apparently it can help with that. Adverse effects are going to include nausea, diarrhea, sexual dysfunction, serotonin syndrome. Okay, now coming over here to our third line drugs, we have our tricyclic antidepressants. We're looking at amitriptyline. That's a really big popular one, used a lot. Imipramine, desimipramine, nortriptyline, protriptyline, triipramine, clomipramine, amoxapine, doxapine. Man, there's a lot of these guys, okay? These TCAs are not used as much as the SSRIs because they have more adverse effects. The adverse effects are more serious. Let's talk about some of those adverse effects right now after we cover what a lot of these are used for. Desipramine has some less serious adverse effects. Clomipramine is for obsessive compulsive disorder because it deals with more, this is SERT, stands for serotonin reuptake, or serotonin, I don't know, I can't remember the word for that. We'll cover that later though. And then norepinephrine, I think there's a channel or something like that. Amoxapine, this is a last resort medication for major depressive disorder, but it has really serious Parkinsonism symptoms, and the doxapine is a soporific. So for this class, they're not used much today. They're very third line, and tricyclic is like 3. Third line depression, chronic pain, enuresis, insomnia. These are all some adverse, some things that they're used for. So if a person has, since they put you to sleep, you give them this and it helps them go to sleep. These different things like that. Some adverse effects of this medication include the 2D6 interaction with SSRIs. So if a person's taking an SSRI and you want to put them on this, you got to put some space in between there because it can have some really negative effects. Also the sedation, the dry mouth. The dry mouth can lead to dental decay. That's not good. Adverse effects also include blurred vision, weight gain, sedation. This might be because of their histamine effects, Orthostatic hypertension is probably because they're alpha-1 alpha adrenergic effects, and also sexual dysfunction because of the same. Now come over here and look at the monoamine oxidase inhibitors. We got phenelzine, which is a last resort major depressive disorder, isocarboxazid, tranylcypromine, and selegiline. Now these are like practically never used. These are like fourth line, okay? Why? Well, look at this huge list of adverse effects. Okay, they got a lot and they're really serious and people can die from them. So selegiline is usually used for Parkinson's. Very last resort. It blocks something called tyramine. So if you're taking, or like metabolism of it. So if you take food that had like a cheese or bratwurst or wine, things that are high in tyramine, because of this monoamine oxidase inhibitor, you get the buildup of these things in your body that can cause you to die. So it's not a good thing. Hypertensive crisis with tyramine, so take tyramine, that's not good. It's more sedating, so it puts people out. Orthostatic hypertension, weight gain, anorgasmia, insomnia, restlessness, serotonin syndrome, tons of contraindications. There's like a huge, you fill this whole screen with the contraindications with this drug. All right. Now, you're probably feeling anxious at this point. It's okay. We're going to cover the anxiety drugs later on. But here's a quick overview of them. We've got short-acting, intermediate-acting, long-acting, alprazolam, triazolam, midazolam, lorazepam, oxazepam. Then we have the intermediate, which is lorazepam. This is dose-dependent. Lorazepam, alprazolam, oxazepam, clonazepam, temazepam, estazepam, and then that was a mistake there. Long-acting, diazepam, quazepam, chlorazepam, flurazepam, this is the one of the longest, and chlorazepate. And then over here, though, this is a little bit more useful. So with the drug-drug interactions, it says CNS depressants, alcohol, narcotics, antipsychotics, and histamine. So these have interactions with all those things. Got to be careful giving those. And also the CYP3A4 drugs. Panic disorders, agoraphobia, and anxiety disorder, general anxiety disorder. For those three things, you can give something called alprazolam. We're going to cover all these more later too. Don't worry, I'm just covering it now so that you've seen it once. When we cover it the second time, it'll make better sense. Panic disorder, anticonvulsant, clonazepam, pre-op sedation, midazolam, sedative hypnotics, estazolam, flurazepam, temazepam, quazepam, and triazolam. So you're probably wondering, why am I covering all this, just reading stuff off? Well, the reason why is typically when you're going to learn something, there's some studies done. If you do a quick overview of everything you're going to learn first, when you go to actually learn it, it'll stick a lot better. And so later on, we're really going to go over and actually learn the stuff. I've got ways to memorize this, so don't have any anxiety yet. We're just don't worry about learning anything. You're just hearing words, okay? All right. So now we're looking at the antipsychotics. All right. So we looked at the antidepressants, and we looked at the anti-anxiety medication. Now we're looking at the antipsychotics. Okay, these are for those thought disorders. So we've got typical, atypical, and we've got our mood stabilizers. So under our typical, we have something called the phenothiazines. These are nice because they all end in zine. That's pretty cool. Risk like seizures. One of the big risks with these, though, is this Parkinsonism. The weird movements you get when you take these. But we've got chlorpromazine, thiordazine, fluphenazine, prochlorperazine, perfenazine, promethazine. So all these drugs here, for the most part, cause extrapyramidal adverse effects. That's that shaking Parkinsonism we were talking about earlier. A lot of them cause this long QT interval. This is on an EKG. It's basically a certain part that gets elongated. Some of them are used as antiemetics. Here I kind of went over some of the reasons why you have some of the adverse effects. Another adverse effect of these phenothiazines is something called increased prolactin. And prolactin basically can cause women to not be able to have children because they stop having periods. It's almost like they're breastfeeding. It's this part of the brain that has tubero in it. I didn't write out the whole thing. I can't remember the whole word. But anyway, tubero, part of the brain associated with prolactin. The dopamine 2 acts there and is blocked there, and that increases prolactin levels because dopamine is the inhibitor of prolactin. Nigrostriatal, I think it was. The blocking there is what causes these Parkinsonism type movements. The histamine, where that's affected, causes sedation. There's the mesolimbic and meso something else. That's what actually works to remove the positive symptoms of schizophrenia. So I don't know why that's in red. That should be a good thing. Sorry. The treatment is that this treats the positive symptoms. Now, positive symptoms of schizophrenia were things like hallucinations and delusions and that sort of thing. You get the dopamine block and the substantia nigra. That's going to be the Parkinson. I talked about that earlier. Okay, so then alpha 1 blocking causes the orthostatic hypotension as well as problems having sex. It's the 5-HT2A that removes the negative schizophrenia symptoms. But I don't think that's actually done here. I don't think this does much for the negative. I think the negative is mostly covered in the atypical, which we'll get to in a second. So haloperidol is a very potent drug down here, similar to thyroxetine, but it's not used very much. It's very potent, and so usually it's used in cases of like some sort of psychotic episode where the person's trying to hurt people and that sort of thing. Long QT, acute psychosis treatment. There is a long-acting intramuscular that's haloperidol decanoate. Has a low hypotension effect. It does cause those extrapyramidal adverse effects. Also, there's a condition where the person's eyes will roll up in their head will kind of get deviated off to the side, and their back will arch. That's what can happen if you give too much of this stuff. And there's also pimozide. Methylene blue is a mild MAO. It's like a malaria treatment. And then there's metoclopramide, which can cause tardive dyskinesia and does block some dopamine 2 receptors. Don't worry about those. Over here, antipsychotics, atypical. Now, I put a note here that the D2, in other words, the dopamine 2 blocking is greater in typical than the serotonin blocking, okay? So, dopamine more than serotonin, okay? And that's a lot of the reason why you get these effects. Whereas these guys, the atypical, actually block the serotonin more than the D2. And this D2 is with the GI subunit antagonism. So more serotonin with these atypicals. So some of the atypicals here listed, these are probably the three most important down here because they have less movement disorders associated with them, but they do have higher weight gain. Olanzapine, quetiapine, and risperidone. And I'm explaining all these pictures later, don't worry. I'm going to get to that. Right now I'm just exposing you. Ariprazole, loxapine, ziprasidone, clozapine, paliperidone, asenapine, lurasidone, iloperidone. A lot of these different drugs here. Important thing here with clozapine is, remember, clozapine associated with the agranulocytosis, seizures, myocarditis, orthostatic hypotension. Lots less movement disorders with clozapine. Quetiapine is also a very good option for that as well. Really, all these atypical have a lot less movement disorders, so Parkinsonism type stuff. Over here I list some more adverse effects. So one of the issues with all these, I'm going to explain a little bit more about the Parkinsonism. Why is this occurring? So basically what happens is the Parkinsonism symptoms are related to dopamine, particularly dopamine that's being blocked in the I believe it's nigrostriatal. I believe that's the word. Substantia nigra, I think is what it is, yeah. Substantia nigra. So you're blocking the dopamine, the substantia nigra, and that's what's going to cause these movements. So you can cause the movements by blocking it too much, but another one of the things that can happen is that blocking it, by the way, creates more of it. So you've got too much dopamine causes the shaking, if I'm understanding correctly. But another thing that can happen is that if you use it for a very, very long time, the body can start to compensate by creating more receptors for dopamine. So even though there's not very much dopamine, there's so many receptors to it. In other words, the sensitivity has increased, or you have dopamine hypersensitivity. It's that hypersensitivity that then causes those movement disorders as well. So in that case, actually giving them more of the drug would make the movement disorders go away, and they call this tardive. Tard means to slow. So it's like tarded or tardive dyskinesia. It's basically the Parkinsonism symptoms happening much later. So with these tardive symptoms, if you were to give them more of the drug, they'd actually go away, and if you were to give them less, the symptoms would get worse for a while until that hypersensitivity went away. So just something to be aware of. And also, benztropine doesn't work if they have the tardive dyskinesia. Now, if they have just the Parkinsonism movements in the beginning, not the tardive, not the later on, but just the original one, this is kind of confusing, I apologize, you can treat this with benztropine, and then you can switch them to a drug like quetiapine or clozapine or something like that, or one of these other ones. Olanzapine's fine. So, important thing to note there. Now, these mood stabilizers over here, we've got lithium, and then we've also got some anti-seizure drugs. So for lithium, some things I noted here is that it's usually used for bipolar disorder, but also for like mania and depression, those sorts of things. It's just kind of a mood stabilizer in general. If the person's depressed, you probably want to add an SSRI to it. And if the person has toxicity, then you want to monitor that these are the different symptoms associated with the different stages of toxicity. So there's toxicity that's just happens at any dose, and that's going to be the tremor, thirst, edema, and weight gain. And it's the weight gain which is the main thing that causes people to stop. There's also toxicity associated with 1 to 2 molar equivalents per liter. And with that one, they have diarrhea, vomiting, they feel drowsy, they have uncoordinated movements. Hydrochlorothiazide or ARBs or angiotensin blockers, those kind of things, those can increase the amount of lithium, which and in any of those instances, it shows up on an EKG or an ECG as a T-wave inversion. Okay, just remember that. So if the person has 2 to 3 molar equivalents per liter in their blood, then you start to manifest as ataxia. They're peeing all the time, really dilute urine. They get tinnitus, which is that ringing in the ears, and they get blurred vision. And if it gets above 3, this is where it's really dangerous. People die. You might need to give them IV fluids and hemodialysis, coma, seizures, arrhythmias, hypotension, that sort of thing. Anti-seizure drugs now, so we're moving on to, these are also used as mood stabilizers. We've got carbamazepine, lamotrigine, valproic acid, and oops, I covered that up. Divol something. Carbamazepine, the adverse effect with this one is going to be hyponatremia, which means not enough sodium in their fluids. Lamotrigine, adverse effect of this one is Stevens-Johnson syndrome. This is a lot of times used for long-term mania prevention. So they've had the mania episodes and you want it to stay away. And then there's valproic acid, which has increased ammonia levels. And I believe I covered all those now. I'm going to move on here to the next section here. So now what I've done is I've kind of zoomed in up here. You see this little circle here? I'm zooming in right here. And I think I'm going to go ahead and maybe end this part of the video that's getting a bit long, and we'll cover up the rest in a little bit.